basically you're evaluating your goals, right? Did you meet your goals? Did you not meet your goals?
Is it each group or each person?
Each person. Now, I told you wrong.
Okay.
And I started thinking about this, like everybody needs to be graded. So also, you know, you turn in different things along the way. So it's up to your advisor to look at that and make sure, you know, you needed to correct anything that you did. If not, then you'll need to correct it because everybody's got to get at least a 2 marks. Okay? It's a clinical grade. Okay? Any other questions? So there is a rubric, and it is on task screen. So everybody has to submit something in that last week on task screen for the STEM project, and that will be your evaluation. Now your audit sheet's kind of rough because you can't, you know, it's not, your paperwork's not even due until the following Monday, and then if you're a weekend, it's like Tuesday, right? So as soon as you can get your audit completed by your instructor, you get feedback from your last clinical week, which is this week, and also put your audit in there, okay? So you're going to put your evaluation and your audit in that last week, that step, okay? Everybody clear? No? Good? Because you can submit more than one thing, right? Okay. All right, we'll read about that. Let me know if you have any questions. All right, well, let's go ahead and get started with our postpartum childbearing family and newborn. And this, you know, can be familiar to you at this point, right? Because you've been, most of you have been to the OB, right? Got to see some babies born, hopefully, and got to take care of some postpartum moms. So this shouldn't be too bad, right? Okay. All right, so what happens after delivery? What happens after delivery, you know, the uterus has this baby, so it's way out here. It needs to go back down, right? The normal uterus is like the size of our fist, and it has to go right down into the pelvis. So this is called involution. That's return of the uterus to the non-pregnant state. And this starts right after delivery of the placenta, okay? The uterus descends into the pelvis 1 to 2 centimeters every 24 hours. So every 24 hours you should expect, when you palpate that fundus, I hope you got an opportunity to do that. I know you've got one more week, so some of you will do that this week. And it's finger breadth below the umbilicus, right? And if it's above, it's going to be minus, and if it's below, positive, because that's what we want it to do. We want it to go down. So, 1 finger breadth below would be U1, right? 1 finger breadth above would be 1U. And then at U is UU. Okay? But this is what we want. Some people put plus and minus. Okay? So this is a little picture. Alright? So just right after birth, the uterus balls up and is like halfway between the symphysis pubis and the umbilicus. Okay, so right after delivery, if you have the opportunity, it's the best time to feel those funduses because they're nice and firm. And it should be like in the middle here, between the umbilicus and the symphysis pubis. But shortly after that, like 6 hours after birth, it rises to the umbilicus. So the first postpartum day, where are you going to find the uterus? The fundus, the top of the uterus. At the umbilicus, at least. Okay. So what could happen is called sub-involution, and we'll talk more about that. Alright. That means the uterus is not returning correctly. Okay. This could cause problems. Alright. That is sub-involution is the failure of the uterus to return to normal. Most common causes of this is retained placental fragments. Okay, so it's always really important for the doctor to examine the placenta and make sure that there's not missing pieces. Okay, and you can usually tell if there's a big chunk missing. and that would be a concern. Okay, and it can also be due to infection. So this can be caused by retained placental fragments or infection. We'll get more into early signs of hemorrhage and late signs. We'll get more into that. Okay? So just remember, contractions cause compression at that blood vessels, at those blood vessels, right? But after the baby's delivered, after the placenta's delivered, the work is kind of done. So what you'll see a lot of times is that they will give the mom Pitocin after delivery, right? Did anybody see that? And it was on your test, so I'm reiterating that. Yes. And we give that to contract that uterus, right? Because it's like a scab where that placenta was, right? So you need to clamp down or put compression on that scab so you don't have bleeding problems. So right after delivery, they'll start up the Pitocin and get that uterus really good and clamp down. And they usually just run one bag. Okay? So, okay. So what would happen if we didn't have those contractions? If we didn't clamp down on that scab where the placenta was? Bleeding problems, right? Okay. So that's real important. All right. Okay. So the placenta site becomes really irregular and nodule, an elevated area, after the placenta comes out. And what you'll find is with our multiparas, what's multipara? Multiple births, okay? Multiple births. Para is births, right? Live births. So after you have that uterus stretched out more than once, it has to work a lot harder to clamp back down. So these moms typically have a lot of cramping afterwards. And we give them ibuprofen for that, right? That should have been one of your meds. Let me add it to that list. Because did you do that at Northeast? Northeast. Give it round the clock? Or did they have a PRN? Or do you know? No.
PRN.
PRN. Okay. At Rowan, they give it round the clock, every 8 hours. So to make sure that helps with the cramping. And sometimes that's all our moms need, because it's just a cramp. But anyway, we will find it worse for our multiparas. So what happens is the two parts of the decidui form the new cavity, and it's a spongy layer, and this spongy layer is sloughed off as lochia. Okay? Where the inner layer starts the new endometrium layer. Okay? We want this to occur because we don't want scar tissue to form there. Because this is where the next baby will get implanted, right? So this is the healthy way of slopping off that area. It necroses and sloughs off as in lochia. Okay? And then new tissue forms underneath there. So usually this occurs and ends by the 3rd postpartum week. Okay. So the different kinds of lochia are rubra. Okay. With the rubra, it's dark red. Now, if you see bright red bleeding, we're going to talk about that in just a second. But that's not what you should see. It should be a darker red, and that's what we call rubra. Okay. And that will last for 2 to 3 days. So for 2 to 3 days, we expect to see our moms having a moderate amount of rubra discharge. Lochia. After the 3rd day through the 10th day, it becomes serosa. And serosa is the pinkish, okay, discharge that they have. And then about 10 days is when you'll see the alpha. So, of course, we don't usually see that with our moms. Sometimes our C-section moms, you will see serosa, just because when they take the baby out, they take the placenta out, they clean it out better. So our C-section moms don't typically have as much flow, and they sometimes will get into the serosa beforehand. But these are typical. Rubra 2 to 3 days, serosa 3 to 10, and alba 10 days. And it may continue for 2 to 6 weeks. Okay. What we want to always tell our moms when they come out to postpartum, if they pass any clots bigger than a golf ball, or the size of a golf ball, or larger, size of a golf ball or larger, don't flush the toilet, call us, we want to look at it. We won't panic at this point, but it's definitely something that we want to monitor. So anything golf size or larger is something we need to keep an eye on. So once the mother stops bleeding, and typically this happens about 4 weeks postpartum, the cervix is closed. Okay? And anytime after that mom has a pelvic exam with a speculum, the doctor will be able to tell the difference in her cervix that she's had a baby, because the cervix was like a donut. Okay. And now it's like a smile face. Okay. It's had a baby, right? So they can tell the difference in a mom's cervix that she's had a baby. Well, they'll do the exam in 6 weeks. They do the postpartum exam, but right after, So what did I say? It takes. Anyway, so I got ahead of myself. Persistent discharge of lochia rubra or return of lochia rubra indicates subinvolution. Okay, something's wrong. Whoopsie. Once you move past that 3rd day and you move on to the serosa, we should not see the rubra again. Okay, so return of the rubra is telling us that the uterus is trying to get rid of something. Okay, so there could be a placental fragment in there that the uterus is trying to get rid of. So this bleeding returns to rubra. So that is something that we want to tell our moms before they go home to definitely let us know that once they progress to the serosa or further, if they start back with the rubra, it's a problem. Okay. And this can be late postpartum hemorrhage. It's like late postpartum hemorrhage. And we'll talk more about that. Okay. So lacerations can occur, of course, and should be suspected if the mother is, you palpate the fundus is firm, the bleeding is, you're not seeing any clots, but if you see a continual seepage of blood, it could indicate a laceration. So that's the difference, okay? The fundus is firm, and they're not passing clots, you can't express any clots, suspect a laceration. And the bleeding's going to be brighter, right? Because it's a fresh bleed. Okay? So that's something you definitely want to monitor. And also that the uterus is at a good level. It's UU the first day. Okay? So it's firm, it's at UU, and there's no clots. But they continue to see little blood, brighter, suspect lacerations. Okay, back to the cervix. It's soft immediately after birth. There may be some bruising. Lacerations can be in the vagina, they can be on the cervix. If we see that continuous trickle of blood, that's when we would contact the doctor, and he would have to take them to surgery and investigate what's going on. We've got the vagina and the perineum. So, of course, a lot of our moms have a lot of edema. It sometimes takes 3 weeks for this edema to go away. And around 3 weeks, the size of the vagina decreases to a much smaller state and returns to normal at about 6 to 8 weeks after childbirth. That's why they have their 6-week checkup, right? So we can check and make sure that that's occurring. Yes, 6 to 8. So 3 weeks for the vagina, the size of the vagina to decrease, and 6 to 8 weeks for the vagina returns to normal. It decreases in size in 3 weeks and decreases to normal in 6 to 8. There may be, moms may have a problem with dryness after delivery, and it's because the estrogen has been suppressed. So there may be some discomfort in women who have sexual relations. So we want to tell them about lubricants, right? Water-soluble lubricants. And lactating moms have more problems with having lower estrogen, okay? So they even have a bigger problem. So again, we're going to recommend water-soluble lubricant. Episiotomies are sometimes done if the baby is not able to be delivered without a little extension of the vagina. And so we're always checking the mom's episiotomy, right? In what position do we put them in to see that?
Let's make.
On their side, right? You have to knock up that leg and you take a little light and you check it, okay? That's the easiest way to check it. We're looking for RETA, right? Redness, edema, ecchymosis, drainage, approximation. Because some moms can get hematomas down there. And so we want to make sure that we're checking those episiotomies. And those take about 2 to 3 weeks to initially heal, but then complete healing takes several months. And ovulation varies between lactating and non-lactating women. So our bottle feeding moms usually have their periods by 70 to 75 days after delivery. So our bottle feeding moms begin ovulation or resume ovulation 70 to 75 days after delivery. And our lactating moms usually 3 months and up to 6 months, but it may be delayed even longer if they exclusively breastfeed. So, one more time, okay? So, for our lactating moms, our breastfeeding moms, 3 months to up to 6 months, but it could be even longer, the longer you breastfeed. And if you just exclusively breastfeed, sometimes these moms don't have a period until they stop. Comment? No? Okay. But the important thing is we need to tell our moms, this is not a form of birth control. Okay? They may not be ovulating, but they could ovulate, so we don't want them to bank on this as a form of birth control. So breastfeeding is not a form of birth control. Right? So they need to use some other form of birth control. Because even though they're not having their periods, they could ovulate. Okay? Questions about that? So, abdomen. The first few days after birth, the abdomen still appears to be pregnant, which is kind of discouraging to a lot of these moms. The striae remain, and striae you probably talked about, right? Stretch marks, okay. And this is due to the stretching and the rupture of the elastic fibers of the skin. Caucasian mothers, it will fade to a silver or white. And mothers of darker skin, they will be darker and remain dark, but they will fade. So we tell our moms, you know, unfortunately they don't go away altogether, but they do fade a lot. And then in Caucasians, they do turn to white silver. So everyone just knows. Really long. That's a few people. Then, did anybody see this in their postpartum assessment? The rectus abdominis, or the diastasis recti abdominis? I know one of us did. Yeah. The separation of the abdominal muscles can happen, and you can tell it when you're palpating the fundus. Sometimes the fundus happen. It's not going to be a problem. It will go back, but it does occur sometimes in our moms, and we just need to reassure them, you know, just exercising can help with that, and it will return to normal. But it might be something you find in your postpartum moms. And sometimes this is affected by previous tone or the amount of adipose tissue. Looking at our breasts, their breasts, and we don't typically palpate breasts. I mean, we're not looking for lumps or masses, because you're going to find them, especially in our breastfeeding moms, or even non-breastfeeding moms. But so you're going to probably feel some lumps. What we're feeling for when we're doing our assessment on the breasts is the milk coming in yet? Are they still soft? Are they filling? Are they firm? Or are they engorged? Okay. So all moms are born with colostrum in their breast, have colostrum in their breast at birth of their child. Sorry, that's not very clear. All moms have colostrum in their breast when their child is delivered. Whether they breastfeed or not, it's still there. And so there's certain ways we need to treat our moms, whether they're breastfeeding or not. So with our moms that aren't breastfeeding, we want them to get a firm bra on, or sports bras are really good, and we want to tell them not to stimulate the breasts at all, because that will cause their milk to progress to come in. Okay? And it usually takes 48 hours for the true milk to come in. All right? So if we can stop that from happening, then hopefully moms that are just formula feeding will not get washed. But it can happen. Some moms say, well, I think I'll breastfeed. And so they start breastfeeding, and then they decide, no, we don't want to breastfeed. Yes. Yes, the cabbage leaves, frozen cabbage leaves, they do work. Yes, they're awesome. They're awesome. You can put ice packs and cabbage leaves, those help. But binding them up also helps. Yes, the cabbage leaves can help also. So, and then I always tell our moms, don't stand in the shower and let that hot water hit your chest, because that'll stimulate your milk to come in. So you just want them to keep your back in the shower, keep the sports bra on 24/7, and hopefully that'll keep it from coming in. Our breastfeeding moms, no special care. I mean, really not wearing a bra is almost better, because it can kind of stimulate the milk to come in, just not having them firmly pressed against their chest. But we do tell our moms not to put any soap on their nipples. So, what we'll see if the moms get engorged, it's kind of like an overnight occurrence when it happens, it seems like. I know that's what happened to me. Woke up and I had these two boulders sitting on my chest. I was like, what the heck happened? So that's when engorgements, when the breasts are swollen, firm, tender, and warm. In our non-breastfeeding moms, if this happens, you don't want them to express any of the milk, which would relieve it temporarily, but it's supply and demand. So if you remove some of that, it's just going to cause more to be produced. So, it's just better to keep them iced down and firm. And so hopefully, if they never start breastfeeding, this will clear up in about a few days to a week. What we need to monitor on our breastfeeding moms is to make sure they're not having any nipple soreness. So we do check our breastfeeding moms. Our non-breastfeeding moms, we just make sure they have their sports bra on and everything okay, no problems. We're going to leave them alone. Okay. With our breastfeeding moms, we will palpate just to see if, like I said, the milk's starting to come in, if they're starting to, or if they still soft, or they starting to fill, or they burp, or they engorged. We also want to check moms and ask them about any soreness on their nipples, okay? If the baby is not latching correctly, and I'm sure you learned this from your lactation consultants, that it can cause damage to the nipple. So it's really important that the lactation people get in there and work with the moms and make sure baby's latching on correctly. But sometimes it still happens, so we want to check our moms, see if they have any blisters, cracking, soreness. And what are we going to give them for that? Lanolin cream. Okay, they can put that on after the baby nurses, and they don't want to rub it off before the baby nurses the next time. It will be absorbed by then. Okay. They also have these soothies. Did you guys see those? They're called soothies. They're kind of like these gel, wavery things that you can put right on the nipples and really help also. But we do definitely want to keep an eye on those because what can happen if they have cracking and blisters and infection, mastitis. So we don't want that to happen. So we want to assess those. And if they have reddening, that can be a sign of that happening. Usually that is something that happens when they don't know, not while they're in the hospital. All right, gastrointestinal system. Usually they have this huge appetite. Starve to death. And also, they don't usually have their first bowel movement for 2 to 3 days. So I had some of my students saying, constipation. I said, well, we really don't worry about that until the 3rd day. And the mothers worry about that also. Oh, what's this first bowel movement going to be like? So they do worry about that. So we want to make sure that their stools are kept soft so we can give them a stool softener. Some doctors order them right up, and some doctors just have them PRN. So if your patients had any kind of a trauma down there, I would encourage them to take a stool softener. It'll make them feel better. It'll make that first bowel movement. Hopefully we go a little smoother. If there's enough trauma, it can actually, so there's 2nd degree, you got the icing time.
Yes.
Okay. So 1st, 2nd degree, midline, 3rd degree, 4th degree, we're down to the rectum. So they may actually have bigger problems, and they definitely, at 3rd or 4th degree, should definitely be taking stool softeners. And unfortunately, they may have a problem with incontinence, bowel incontinence after birth. But pelvic exercises can help get that area all back into shape. So everybody's encouraged to do Miss Beaver's Kegel exercises. So they really do help, so we encourage moms to do that. Helps that area heal. Urinary system. So it takes about 6 weeks for the kidneys to get back to normal after birth. During pregnancy, the ureters have dilated, and the urinary tracts or the bladder can hold more urine, and so with retaining urine due to the dilated urinary tract, it increases the risk of urinary tract infection. So these moms need to be encouraged to urinate every couple hours because typically they don't feel the urge, okay? So that's why when we go in to do their postpartum assessment in the morning, first thing in the morning, what do we have them do? They've been to the bathroom this morning, go ahead and go. Especially if we palpate and the uterus is off to the right, that's a sign that the bladder is full. And with their uterus or with their bladder full, you know, it's right below the uterus, it pushes that uterus up, and these moms can have problems with bleeding because the uterus can't clamp down as well. Okay, so that's something we want to encourage our moms to get up, go to the bathroom every couple hours, knowing that they might not feel the urge. After delivery, the moms will diurese, and they'll eliminate, this is crazy, 2,000 to 3,000 milliliters of extracellular fluid. Because what happens during pregnancy? How much blood volume do we increase? 50%. So they have to get rid of that extra blood volume. So you will see this occur in our moms, and especially when you lay down at night, then they have to be getting up all night, the night that they diurese. So what happens is the bladder fills rapidly, and so sometimes that stretches it out, and they just don't feel that urge to go. So again, we want to encourage our moms every couple hours to get up and go to the bathroom. Because a lot of times, if these moms have had a really traumatic birth and there's a lot of swelling and they have really bad episiotomy, that also will make them not have the urge to urinate. Okay? So we definitely want to put ice on these moms to help with that. Sometimes we have to catheterize them because they just can't go after them. They just don't have that urge. Our cardiovascular system. Of course, we don't need all that blood volume anymore, right? So we have to get rid of it. So the blood volume decreases. In the first 24 hours, it accounts for half of the RBC volume. The blood loss in the first 24 hours accounts for half the RBC blood volume gained during pregnancy. So they lose 25% of that 50% they gained. In the first 24 hours, they lose about half of what they gained during pregnancy. Okay? So a normal blood loss for a vaginal delivery is 200 to 500 milliliters. And with a C-section, they can lose up to 1,000. And that's considered normal. So we don't have as much blood volume, so the cardiac output is going to decline, right? So the cardiac output declines by 30% in the first 2 weeks and reaches normal levels about 6 to 12 weeks.
Repeat that.
Cardiac output declines by 30% in the first 2 weeks and reaches normal levels by 6 to 12 weeks. So about 6 weeks, everything should be pretty well on its way to.
So the slide should be cardiac output is decreased, not elevated.
You're exactly right. Yep. I will make that correct. Decreases. Vital signs. So the blood pressure usually remains pretty stable, which is typically low. Have you noticed our mom postpartum moms' blood pressures are really kind of on the low side because they have all this extra volume when they come in to deliver. And it usually stays about that. And of course, if they lose a lot of blood, they may have a lower blood pressure. So it's something we definitely want to monitor. Sometimes our moms will have orthostatic hypotension. And this is common in the first 48 hours. And it's because of all the abdominal engorgement that's occurred after birth. And bradycardia is common, 50 to 70 beats per minute you'll find with our postpartum moms in the first 6 to 10 days. And again, the body doesn't have to pump all that blood, so the heart can slow down.
She's at 16 seconds.
So typically you're going to see a pump on both side blood pressure and bradycardia 50 to 70 in the first 6 to 10 days. So if it's much lower, I mean, if it gets really low, sometimes they dehydrated because and they have bolus some fluid afterwards. Her blood pressure was like really low. Okay. All right. Other concerns. Lab values.
What did you say? I'm sorry, about 25%. At some point you were talking about the blood volume in the first
Yes.
24 hours.
So in the first 24 hours, they lose, okay, so they gain 50% additional blood volume
Okay.
pregnancy. They lose half that, so I would say they lose 25% of blood.
Okay,
Half of it.
that makes sense. I just wrote it wrong.
Yeah, half.
Okay.
That confused me. Okay. All right. So lab values. Have you noticed that the white counts are kind of high? You guys probably talked about that. It's normal for our pregnant moms when they come in to have elevated white counts. That's normal. In preparation for the delivery, maybe, but it may be confused with infection, right? That's usually the lab value we look at to determine whether there's an infection. So we can't really determine that mom has an infection looking at a white count, right? So we want to monitor temperature, because that may be, that should be our better indication of whether there's an infection going on. Hemoglobin and hematocrit are definitely affected. Any of you see some low hemoglobin and hematocrits? And this is due to the change in blood volume, because it's decreasing, right? And then the mom is diuresing. So all that fluid that they're having to get rid of gets into the circulatory system and dilutes the hemoglobin and hematocrit even more. So you're going to see some low hemoglobin and hematocrits. And typically, they don't give them blood. Okay? These are young, healthy moms. You encourage them to eat high iron content foods. Sometimes they're on iron when they go home for this. But typically, you're not going to see. We had one that was 6. Hemoglobin was 6. Yeah. And on med surg floor, you'd be transfusing them, wouldn't you? But these moms are going through all these changes, and it's not really a concern. As long as they're not symptomatic. Now, they get up and they get dizzy and blood pressure bottles out, then they might have to. But so for the first week, that hemoglobin and hematocrit will be low. Platelets return to normal by about 6 weeks. Weight loss. So initial weight loss for mom is about 10 to 12 pounds. And this is with the birth of the baby, the placenta, and the amniotic fluid. Then with all that other fluid that mom has to get rid of, she'll lose an additional 5. So 10 to 12 pounds initially. And this is the infant placenta and fluid. And then they lose another 5 pounds with diuresis. Good positive to encourage our moms to breastfeed, which we all know is an awesome thing to do, right? Because of all the antibodies babies get from mom. It's just perfect. Mother's milk is perfect. So another way we can encourage moms to breastfeed is it helps them lose weight. And it really does. If you've ever been breastfed for a long period of time, it can really help them lose their weight. Baby weight. Did anybody see their moms after delivery have these intense shivers? That's kind of scary. It's scary for the moms too. But this is due to the sudden, it's kind of, they're not sure why it happens, but they have some theories that it may be due to the sudden release of pressure on the pelvic nerves after delivery. So it could be due to the sudden release of pressure on the pelvic nerves after delivery. It could be also a response to the fetus to mother transfusion that occurs during placental separation. Or they thought it might be due to the adrenaline produced during labor and birth of the mom. One other one. Or reaction to the epidural anesthesia. If the mom is not running a temperature, it's not a concern, and even though it's not that they're cold, we give them a warm blanket. And a lot of moms say, oh, I'm not cold, but it somehow makes us as nurses feel better. Another way moms will lose fluid is by perspiring, sweating, also diuresis that way, and of course at night they might wake up drenched. And that's just another way of getting rid of that extra fluid. So as I said earlier, the after pains are more common in our multi-paras, or moms that have delivered more than one baby, than our prima-paras, first-time moms. And that's because of the contractions. And breastfeeding releases endogenous oxytocin in your body, in the mom's body, and that causes the uterus to contract. So it's really nature's way of putting everything back to where it needs to be. So you will notice your moms, if they say, oh, do you find that it's worse with breastfeeding? Yes. And then we can do some teaching. That's the body's way of releasing oxytocin and clamping down that uterus so we get back to where it needs to be. And the best thing we can give our moms is ibuprofen. It really helps with the crampings.
Is ibuprofen okay while breastfeeding?
Yeah, you can do that. A lactation consultant, because that is the common fear that, oh, I can't take anything. It's going to go to the baby. And she made a good point. She said, just because you take it in your mouth is not a direct way to breastfeed, okay? And we want our moms comfortable and able to breastfeed and move if they've had a C-section, and there's very little transfer to the baby. So that's another job we have.
So that's why you can't take it pregnant, but breastfeeding.
Right. It's not a direct line. Now, when you're pregnant, it is. And yeah, it's a direct line. With breastfeeding, it's not so much. Ideally, it's better to take that after they breastfeed, but that's not what they're having. So try to time it where they can take it. All right. Thank you, everyone. So I'll see